Good morning, everyone. Welcome to our fifth webinar series for the BOG review session. It's the fifth and the last, so time flies. So, and we thank you for being with us until the end, until the fifth session. Your dedication shows that you are really dedicated to your fellow journey. Your presence shows your dedication to the fellow. What we have in store for you today is we'll be tackling the healthcare technology and information management. So it's 18 points of the exam, and we will be also doing the quality and performance management for today. So without any further ado, let's move on to the next slide. So as usual, these are the members of the advancement committee who made this webinar series possible. So I'd like to start with myself. I'm Michael DeCoco. I'm the chair for the committee, and we don't have TUI for today. So let's move on to Rick.
Morning, everyone. Rick Nearite, Cal State Chico.
And Sasha, you're on mute.
Hi, this is Sachin Gangupantula. I'm the Director of Operations at Valley Diabetes and Obesity, been with CAHL for 6 years or so, and with this advancement committee for 3 years. Thank you for joining us today.
Hi, good morning. Nora Powers with Aetna, and been on this committee since its inception in 2011. Hard to believe. Welcome. Good morning.
The next slide, please. I think we have our San Diego Organization of Healthcare Leaders Partners online? So, okay, so we'll just move on then to the next slide. I think they're not here. Okay, this is for Nora.
Okay, we've been saying this consistently throughout. We're going to be sending out the SurveyMonkey app shortly after this, maybe a couple days, but we'll be sending it out. And again, please be very, very honest, be very thoughtful. We do take the results in consideration as we continue to improve the program. So the most excellent award-winning presentations, we've had this session so far, are built on the results and recommendations from previous sessions. So you've got to pay it forward. Also, remember, this is worth 8 continuing education credits. You self-report those on your MyCHE profile, as you get into the ACHE website, and you'll self-report those. Okay, next slide. Okay, so we've got a couple some upcoming events on May 5th. This is the collaboration between HFMA in Northern California and CAHL. We try to do this at least once a year to have some sort of joint session with another healthcare organization. And that's on May 5th. And then on May 10th, there'll be face-to-face credits. So remember, for your education credits, you can get continuing education or the qualified education, and you need the face-to-face. And so this will be just building better bridges for healthcare and their community. So again, the good news is through ACHE and through your local chapters, you should be able to get all the credits you need to be able to qualify for advancement.
Next slide. I think this is for the Seoul events chapter. They'll be having their virtual networking Seoul and in collaboration with ACHE Southern California. So just go to their website. If you are from the chapter, go to your websites and you can see further information with that event. Okay, next slide. Our next topic will be the healthcare information technology. So we have a speaker in house who is also a member of our member advancement committee. So Sashan is the founder and director of operations at Valley Diabetes and Obesity. He used to be also the past chair for communications committee for the CAHL, and as I mentioned earlier, a member of the advancement committee, and Book of the Year committee. He's part of the Book of the Year committee for ACHE in Chicago, and a recipient for ACHE Healthcare Executive Regents Award. So he has a master's in business administration with focus in healthcare management, and he is also a fellow. I think he just recently passed her fellow exam like a year ago, right? So without further ado, I'd like to introduce to everyone Sashan Gagumpantula.
Thank you, Michael. Great to see you all this morning. Thank you for joining us. As Nora pointed out, we love your participation in these sessions. We are proud to say that we are able to produce fellows every session consistently, and would love to hear from you when you do get through the exam, so we can actually feature you on our website as well. As part of the communications committee, I'm also responsible for sending our communications out, especially with the advanced committee updates as well. So would love to include you in our newsletters as well as the website. All right, so today we're going to talk about healthcare technology and information management. I believe it's 18 questions amounting to 9% of the exam. Even though it seems a small percentage, obviously it's one of the key domain areas. And we all know that technology plays a humongous role, and it now has a voice at the table as a CIO who's representing technology on the strategy as well. And if I recall correctly, I think a few years ago, the questions, there were 12 questions amounting to 6%. So as we see the increasing relevance of technology in our healthcare industry, you do see that the fellow at the Board of Governors exam is also updating in terms of the weightage associated with technology. So as of this year, we have 18 questions with 9% of it. So here's some of the topics we are going to cover, or this is as part of the domain knowledge here. I think if you think about the role of health IT, there are some stark numbers that actually, are more relevant than ever before. I think the last study I read in 2016, we had over 250,000 deaths attributed to medical error, and that's number 3 cause in the country. It's not even clinical. So, the biggest challenge we have really driving the medical errors is really not having, there are multiple reasons, obviously, but technology plays a huge role in terms of sharing the information, providing the right information to the staff and to the physicians at the right time, and several others that directly relate to the information technology and the applications that we have. So that's kind of a key driver in terms of where we are for the healthcare technology. Our mandate, as we all know, is to provide a safe, timely, efficient, effective, and patient-centered care. And each of these attributes have a piece of technology that enables those for us. And every day you walk into, it doesn't matter what healthcare facility you are in, you can see the impact of applications, technology to actually deliver on our mandate here. So overall, the domain covers several aspects of our technology, starting from the role of strategy, steering committees, governance, and as you move along in terms of planning and implementation of these initiatives. Regulation, policy and regulations are the ones that drive a lot of these initiatives for us. Back in 2009, when we had the ARRA Act that basically kind of drove the HITECH Act and the adoption of EMRs, it was, much needed kind of enablement to allow us to digitize our medical charts, a lot of the medications and the services that we provided. Fast forward to today, we have directly or indirectly, the technology has become more complex, but also it created a lot more challenges in terms of security issues, in terms of piracy, in terms of ransomware. So medical data, health data is a strategic asset, if you think about it, and it needs to be protected, needs to be managed, maintained, shared, and collaborated with across every step of the way. And what we have in this domain is basically covering all aspects of that and enabling that team to really provide these services that touch all aspects of our delivery. Let's see here. Let me see if I missed anything here. Part of the information, the data that we capture, as I said, the security and the access to data is super critical. So information systems continuity, which includes disaster recovery and planning, becomes so much critical. COVID is a great example where we kind of uncover a lot more gaps that we have in terms of access to data, in terms of just sharing the data across facilities. And if anything, that's kind of a wake-up call for a lot more health systems to prioritize where we are on the technology curve. And last but not the least, if you look at healthcare analytics, that's where we are taking the data that we have, making sense out of that as knowledge, and also moving it further along to actually give us more recommendations. If you've heard of ChatGPT, that kind of gets to the another example of where analytics plays a huge role in terms of not just enabling providers in terms of doing the right thing, recommendations in terms of clinical care, in terms of future diagnostics, prescriptions. All of these comes into the play when we look at the analytics. The healthcare informatics is another example of the impact that these solutions have on our care delivery. That kind of covers all of our areas of focus here. All right, let's move on to our.
Can I interrupt?
Yes.
Before, just really quick before, the ACHE reference manuals, resources include the well-managed healthcare book. There is a entire book in and of itself, IT, as well as the flashcards. So plenty of opportunities to get some good info. Go ahead, sorry.
No problem. So let's go over the questions here for our practice. Let me just, okay, the first question, Nora, if you could just monitor the chat, just let me know what the audience is giving as responses. Do encourage all of you to kind of give your best answers here so we kind of address them. First question is a CMS program that requires provider to consult a qualified clinical decision support mechanism for the appropriateness of diagnostic imaging services is called. Here are the four options we have. I'll give a few seconds for you to let me know your choices.
So far, we're getting C's. Consistently, we're getting some C.
All right. So we go, one thing that healthcare technology, obviously, several of where the decisions we've made in terms of policies have resulted in acts that have resulted in incorporation of new technologies like EHR, but there have also been several acts that actually expanded care, expanded protections, etc. So there are, fortunately, there are only a handful of them that we have to kind of remember. So if you go through these, each of these actually are related to the acts that have been passed. Like meaningful use actually is part of ARRA. The Health Information Technology for Economic and Clinical Health Act, actually HITECH is also part of the ARRA. All of these have directly impacted where we are. The specific question here, the answer here is actually B, Protecting Access to Medicare Act of 2014. It doesn't jump out exactly what that is. So if you don't know what it is, it's going to be hard to guess. But this act was passed in 2014 to basically focus on making sure that the Medicare beneficiaries have access to diagnostic services, both in terms of funding as well as providing kind of options for reforms to make sure that there is physicians are actually mandated to use decision support system. So as I said, kind of, I think we have what I did for my preparation was to have a cheat sheet for some of these laws, just to highlight like one-liner, two-liners about what each of these is. So in this case, it's option B that actually talks about use of a CDSM for this solution.
I did not know that. So this
So this is this is Michael. Just to expand more on that, on the PAMA, we call it PAMA Act of 2014 for ancillary services. So this is also encompasses the laboratory, actually the proper use of all the testing. So it's not only directed to diagnostic imaging services, but it's mostly directed to the ancillary services like the diagnostic, lab. So to make it sure that there's no inappropriate use of tests being ordered by the provider. So
yeah, it was back in news again. I think there's some aspects of the mandates that were supposed to be going effective January 1st of this year that was delayed.
And there's coming soon. So just for FYI for those leaders for operations here, what we call the there's another mandate coming related to diagnostic services also, which is it will mandate outpatients as well and ERs about about decision support mechanism. So.
All right. Second question. The COVID-19 pandemic played a significant role in the expansion of telehealth with 1135 waiver by. Let's choose one of these options. Let's hear what the team has to say.
Okay, we've got some D's coming in.
Right. I guess it kind of, the D option did give away a little bit of a clue with including telehealth in the answer itself. But always keep an eye out for the choices. In this case, all of these are related to beneficiaries receiving services, and telehealth, for example, option A, one of the earlier requirements prior to COVID was really telehealth restricted to designated rural areas only. And COVID kind of enabled, or kind of they had waivers to kind of expand that. Option B actually has nothing to do with telehealth, but it's a default service of Medicare Part B. Encouraging a non-face-to-face communications through online portal services. It's part of telehealth, but again, it goes back into what was enabled during COVID without much restrictions. So option D is the right choice, basically allowing the waiver allowed Medicare, and pretty much most commercial insurances to allow providers to provide services through telehealth, both audio and visual services, including patient's place of residence. Nora, if you do see any questions or comments, do let us know so we can address them as well. All right, let's move on. Question 3, why is it important for the IT strategy to align with the organization's goals and objectives? This goes back to my earlier comment about how IT has a huge role to play in terms of being present at the table, in terms of setting strategy, in terms of being part of the executive team itself. And that's one of the key lessons we have to kind of learn as part of going through this. You know, if I've seen, even when I appear for the exam, there at least one question that consistently got repeated, which was around this. Steering committees, the role of CIOs at the table, and why is it important for health IT to really be aligned in every form with the organization's goals.
So we're getting Bs, lots of Bs.
Awesome. I think that was an easy one in a way. So if you look at options A, C, and D, they're all part of being how important IT is, but B is the one that gets the most broadest perspective of the role of health IT. And I think we kind of reinforced this thought all through these 5 weeks, which is look at options which give you the broadest scope of relevance. Option A is kind of irrelevant in terms of what the question asks, but B, C, D, in a way are related to the question, but B gives us the best answer in terms of making sure that whatever health IT does from a strategy point of view is meeting the goals and objectives at a strategic level for the entire organization. All right, moving on. What competencies do not matter in selecting a CIO? This is also kind of an easy one, I guess.
Got some Cs coming in.
All right. I want to say it's a no-brainer, but all right, let's do that. Question 5, when introducing a new information technology system to a healthcare organization, resistance can be effectively addressed by.
This is a good question.
Definitely.
Getting some Cs.
Great. One of the most cited surveys or kind of impacts that we've seen is the success of health IT applications, solutions, technologies, any of those, pick any of those, the success of how successful the rollout was. The biggest challenge all organizations have really is the failure is caused by one or two things. One is not having enough of an executive sponsor driving the change. The other one is change management. What it is not preparing at every level your users and departments, the end users, understanding what rollout means and helping them understand and be trained along the way to make sure that they're ready for that change. But the one that's gets a lot of focus is not having the right users or stakeholders in your implementation, and not having the end users. So the actual users, whether it's nurses, it's the front staff, not including them at the right time, right from the beginning, all through the rollout, training, etc. That's actually the largest impact in terms of the failure of the projects. So the resistance that we are talking about in the question is usually coming right from there. A lot of folks who've been through a bitter experience of an application is because they were not engaged at the right time, and they were forced to use an application without understanding the value that it provides to their department and to the entire organization. So by including or focusing on the system users, which is really the end users that are going to be part of the system, it's going to impact your success of that rollout. So C is the right option.
So, can I, so if I'm looking at this question and the selection, I can also see that B is a possible answer, right? Because we need to employ also a policy. Or what do you think? What do you think would be the best?
So agreed. I think part of, being executive sponsorship of any initiative as big as this, like is an Epic rollout or any EHR rollout, is definitely, making sure that the sponsors are spelling out the purpose of this technology initiative, but more importantly, as an organization, they're moving forward with it in terms of making it a mandate. But a lot of times, you can only get a success out of each of these end user groups to effectively use the system is if they understand and appreciate why that mandate exists in the first place. So it goes hand in hand to say that the sponsorship or the teams are actually working with each of these departments to help them get along or understand the value of the system and how the workflows are going to be improved, maybe even revolutionized by using electronic methods of communications. That'll help them kind of get along on your side and appreciate the value of it. So yeah, the mandate goes with it, but without having good change management processes and also enough training and also representing them into all of these interactions, in the end, you will not have enough of a success of the adoption. Great question. All right. The best way to facilitate information system integration within a healthcare organization is, let's hear what the team says.
Getting lots of Ds.
Perfect. You have a pretty smart
I know.
cohort this time. So we go through the options here. Somehow it's just a hardware and software combination here, the ABC. They do help in some contexts, but they all have limitations in their own way. I think in this case, D is the best choice because over the years, what we've seen with health information technology is that we have tried to build a lot of piecemeal solutions. If you take the epics and the big ones out of the picture, a lot of health systems at different scales ended up creating or buying a lot of this health software to help them do, labs have their own systems and financial systems have their own. They still do, because you can't really invest in one huge infrastructure and hope that it works well. Like what option C says, even using an Epic, it's really focused on your electronic health records and how you communicate the health data to other organizations, but it doesn't really help you with rest of the company in terms of finance, human resources, and a lot of others, right? So we end up having a lot of these systems in place. And the only way we would be able to communicate is through integration. And this integration requires what's called as, standard data definitions, which is understanding that there is a common language that every system can speak to. I'll give you an example of our practice. A year or so, we migrated from one EHR to the other. As you know, EHRs end up being silos in their own way. And it's hard for them to really talk to each other. So for us, the challenge was we have 4 or 5 years worth of labs that we have saved or got from our partners like Quest and LabCorp that we get the data from. And the best part was that there are certain standards that have been adopted by the industry. Some of them have been really successful. One of those standards is called HL7 for Health Level 7. And what it is it basically encapsulates all of your patient data in a format that ideally every EHR vendor should be able to understand if it's a certified EHR. And Quest basically said, I asked them, can you get me last 6 years worth of my lab users lab data, all of the labs that we did. So I want to hand it over to my other EHR so they can just consume it and show the data. So thanks to this standard definition we had, Quest was able to share with me one file. It was not even a huge file, but they gave us that standard data file that I just handed over to my new EHR vendor, and they just consumed it, and they was able to just import all of the data right from Quest into the system. So it was probably an hour's worth of work. That's it. Imagine if you have to manually do this for 1,500 patients over 6 years worth of data, right? Without that standardized data, one application does not understand how lab values are organized or how to represent certain specific values. So always look for, in the health IT world, standardization, data definitions are really the key way we look at how we can interoperate between systems and between organizations. All right, moving on. Knowledge management is defined as, and this is something that's relevant not just to healthcare, but a lot of other industries, but and that's why if you look at the answers, it's a very generic answer. It's not specific to healthcare.
Happens to be one of the flashcard
Oh, perfect.
subjects.
The flashcards are really helpful. I was able to benefit from that as well. I used it like a couple of weeks before the exam to kind of refresh terms and terminologies. Definitely get those.
And again, this is one of there's a lot of words in this one. So I can see people are taking their time going through, which is good. Got a B, an A, we've got 2 A's. More A's.
All right. So knowledge management, as I said, in a general term, it's basically, if you look at how our healthcare data is the most valuable asset, and I'm trying to recall the exact phrase that we used in the context of health IT. Health IT exists to make sure that we are leveraging, maintaining, protecting all of this data that's so valuable for us. So the challenge is also that information and data is in so many different forms. Think about lab data in some structured form, but we also have electronic health records. A lot of it is free flow text. Some of it is structured, some of it is not. But at the end of the day, all of this information needs to be collected, managed, maintained. And also at the end of the day, it's not just about, for the clinicians especially, this asset is not just about current patients' health, but they also need to build up expertise in evidence-based practices. They also need to share this information with other clinicians, other providers within the organization. So knowledge management has been applied to healthcare in the same way, where this information can be gathered, maintained, and updated, renewed in this case, so that they can share it with all of the entire organization along the patient care delivery. So that's really what A is about. The transfer of structured information between two computer systems, it's not knowledge management as much as sharing the information. So yes, you can have an intranet, or you can have an application that allows you to share the information between two computer systems. But this goes back to, again, the definitions. Whenever you're looking at each of these answers, look at how broad the answer is and whether it covers the broadest possible scope, right? So B is kind of limited in that sense. The movement, option C, a movement to explicitly use the current best available scientific evidence. It's true. This is the evidence-based mechanisms we have, clinical decision-making tools that we have, but it's only one step of that. Option C is talking about one aspect of knowledge management. And option D, controlling of resources to accomplish goals and objectives related to a distinct initiative. So this is kind of similar to what A is talking about, but it's kind of limited to one initiative, and it's also talking about resources. But assets are a much more larger, valuable component that includes a lot more information than just one resource. So if you look through these options, option A is the closest, or actually the accurate definition for knowledge management. Did we have any other questions or comments about it, Nora?
So, Sasha, this is Michael. I'd like to add some context on this question. Mostly the selections are a definition of terms. So if you probably encounter these terms, the letter B, the transfer of structured information between two computer systems, it is a definition for electronic data exchange, interchange. That's
EDI,
yeah. So EDI, I guess. The C, a movement of explicitly use the current best available scientific evidence of managerial decision making. It is referring to the evidence-based management. And the last one, the planning, organizing, directing, and controlling of resources to accomplish goals and objectives related to a distinct initiative. This is referring to a project management. So those are, I think this selection are just nuances or some detractor, confusions that they just put there to confuse the test taker. So
Right.
just
Very good point. And I think the book that Nora showed us early on, it actually has, in addition to the appendix, it actually has a section at the end that actually goes through all of these acronyms. It's a great resource. All right, moving on. Which of the following is the reason that system support of outcomes, data collection, and analysis can be very complex? And we kind of touched on this in the last couple of questions. They should give you an easy clue there.
Got some A's. More A's.
All right.
Got a C. A's. C.
All right. So this is tricky because all of these contribute to the challenge we have in the question, right? And we talked about this a little bit. So option A is definitely relevant because at the end of the day, what we see on a day-to-day basis is that data is spread out. It's segmented. It's across different systems, and a lack of. I mean, there are solutions for it to bring it together, which we talked about, right? Option B, the functional departments are not integrated with financial information systems. True, but the question doesn't talk about financial systems specifically, just talks about outcomes, which is more related to patient care. So option B is something that I would take away right off. C, there's an inconsistent medical terminology across clinical systems. There are standards now across different areas, so I won't agree that there's inconsistent medical terminology as of now. I gave you an example of our labs. There are also standards now that actually even represent lab values using certain codes. So I feel that option C is also something that's relevant. Option D, variation exists between open system architecture, interface engines, and multimedia data entry options, which is very true. I think as much as we have standards, some of them have been widely adopted, but there are some that are still not widely adopted, which will create this challenge for us. In this case, if you look at go back to the question, the system's support of outcomes, data collection, and analysis. Option D does point to a cause to it, but the biggest reason why we have this challenge is really because the data is really spread out across different systems. And a lot of times in manual systems too, we have still patient data. Some of it is paper-based. A lot of clinicians still do paper-based charts. So that's really makes it harder for any health system to really look at patients' outcome data. So in this case, option A is really the best answer.
And again, you're hitting on the point from the previous question, and several have noted here.
Right.
When you're talking about it, again, you've seen me go down rabbit holes, but typically the broadest answer is the correct one. And if you can understand how the pieces fit in, then you can find the broadest answer that encapsulates that. So you did really good at explaining that here.
Right, thank you. All right, moving on. Membership of the IT steering committee should comprise of. So the IT steering committee is one of the key components of the health IT in terms of where the focus is. But understanding what the committee does is super important. I think I have seen this appear in different variations, the same question.
Getting some B's.
All right. So going back to some of the earliest discussions we had, in terms of anything to do with health IT, you need to make sure that we have the right representation, right? Because it's not just a CIO or any of the CXOs making these calls about where we should be going. If the health IT has such a huge role in terms of achieving business goals and objectives, we want to make sure we have the best representation. In this case, if you look at options C and D, it seems heavily stacked with the technologists, consultants and systems analysts. At the end of the day, they will be playing a big role in the implementation. But again, remember, we need to have the right people in the committee to actually make sure we are prioritizing the right initiatives, making sure that we have enough of policy and regulations that are being complied with, etc. So in this case, option B is the right option because it includes not only the administration and the executive sponsorships, but also the physician leadership, because we're going to include so many of technology initiatives, especially clinical decision support systems and services for nursing and other things, which need a lot of the physicians to be involved. And obviously, IT and IS is going to be a big part of it. But the key component is the last one, which is a major user departments or divisions, whatever you want to call it. They are the end users of your systems. And IT steering committee really need to have a good representation of those end users that actually will be not only contributing to it, but also be a major users of such systems. So just keep an eye on this question because the same question gets asked in different ways. Always look at, again, the broadest representation on the committee in terms of all users that will be not only funding them, but also executing them and using them. So if you look at that broad definition, you'll be able to answer the question.
Yeah, and this is Michael. The B is more proactive and inclusive approach.
Great.
Yeah, and A is mostly the C-suite level. They are not the end users here. They can sponsor, as you're saying, that which is right. So
Give you a real life work example from a couple weeks ago where my team needed to know something. The system that was set up forgot to ask us what we needed to know, that one piece that we need to know. Everybody's like, keep looking here, keep looking. We're like, somebody forgot to ask us that we needed that one piece. So I'm sure all of us have that kind of experience. So.
Right. All right, moving on. Selection of an information system in a healthcare organization should begin with. It's a little descriptive, so take your time to read through it.
Okay, we've got B. Some C's, lots of C's.
I think we're on track there. So again, I think information system in a broadest term, obviously it impacts the entire organization. So if the goal is really to choose the right initiative, right project, they have to match up to how it supports existing organization strategies and goals, right? So C kind of jumps out right off the bat. But going back and seeing in option B, hiring an information systems consultant to determine the organization's strategic needs, it's kind of, you don't really bring on consultant. I think it's really should be coming from whether it's the CIOs or the executives that are actually setting up their strategic needs. And the CIO does, and often a lot of health systems do not have enough of a technology management kind of skill sets. So I do see them bringing on consultants to help them in terms of the planning aspects, but it should really be a high-level strategic initiative, and the selection of such an information system should be driven by our own executives, our own steering committee that actually knows what the organization's needs are. And as we get into the planning and execution part of it, that's when you can bring in consultants. So the selection process and vendor selection and criteria is going to be the next steps where you would need help from consultants. But typically we want to have any of this strategy to be set at a higher level, especially with the focus on the steering committee. The steering committee typically also has other subcommittees that will take on some of these definitions as well. But in this case, C is the right option.
So comment on some of the keywords if you're looking at ISP, strategic objectives, when you're looking for those keywords.
Yes. Yeah, and if you look at option A and D, again, those do come into the play as you start getting into the planning and implementation aspects of it. Understanding the overall scope of the project, identifying what the organization has already invested in, understanding how that system, existing systems have to interface with other new systems that you're considering. All of those come into the play as you, and that's where the subcommittees kind of become live once you actually start on the execution part of it.
So what I'm appreciating hearing over in the chat is what you're thinking or how you're thinking about answering that question, some of your logic flow, and I'm appreciating that.
That's great. It's a great learning. All right. Moving on here, in the IT system development life cycle, which is the most important step? The book that Nora showed up front, it's a great book. Talks about all phases of our system development life cycle, in addition to just the steering committees, the planning and implementation, the governance part of it. I know it can be challenging for a lot of others who just don't have much of hands-on with anything to do with information technology other than using it. But it's a good reference book. If you're getting into the leadership roles, this is something that's always going to be helpful for you, because you may be required to decide or set the strategy in terms of choosing a particular technology for your own division. So understanding how health IT really works and what are the steps involved will give you a good sense of that perspective.
So we've got some B's, we've got an A.
Great. I think in this case, knowing the software or system development lifecycle is helps you quickly answer this question. The answer is here, option A. System analysis is really the earliest step as much as also the most critical step, because it kind of helps you understand the overall scope of your project, overall scope of what needs to be done, the requirements from a user's perspective. Like the user should be able to do ABC, but what does that translate into? What does the system need to do? So the systems now, I mean, there's usually any IT department has half a dozen or more systems and analysts, business analysts, whose role is to really engage with the end users, engage with the other business units that are going to use the system, to kind of get a sense of what it is that we are trying to build. And that analysis gives you all of the dependencies you need to have to be able to talk to the other systems. What are the interfaces we need? And what are the risks we have, in rolling this out? That's why it's so critical to do that phase before even we get into the next stages, which is really designing, getting into the nitty-gritty of the technical architecture and application architecture. And if you go down, the system acquisition and implementation kind of goes into the next levels after that to start acquiring, whether it's a software or hardware that we need to purchase, and then actually the implementation, which is really making the system available for the entire organization. So in a way, the answer kind of gave away, because it's a sequential in the way it's shown, how the phased approach is, but it also, in this case, tells you, why systems analysis is such a key component that needs to be done as like a foundation of building any system within an organization. Any questions on that?
So in the interest of time, Shashan, can we put the next question?
Yeah, that was the last one.
That's the last one.
Happy to answer any questions if they have. Great. Thank you so much. Moving on.
Okay, I guess I'm next. I want to introduce our absolute final last speaker of the series, and it is one of my colleagues, Stan Salinas. Stan is associate professor at Chico State. He's chair of our department, Public Health and Health Admin, and program director for the Health Administration program. And he originated and has taught our class in healthcare quality, along with a bunch of other classes, but that's the one that's applicable today. So I will turn this over to Stan.
Thanks, Rick. And okay. I wasn't sure if I had control or not. By the way, I was going to send Twee an updated picture, but I really like that one from 13 years ago or whatever it is. So we'll keep going for a while with that one. So quality and performance management, Sanjan mentioned a couple at the beginning, 200,000-ish deaths from preventable medical errors. Somewhere between 200 and 400,000 is what the best estimate is right now annually. So it's a bunch of airplanes falling out of the sky or train crashes, or however you want to draw a parallel, but there's no social dread around it, so nobody really cares. I shouldn't say nobody really cares. The public doesn't care. Yeah, so a few things to broadly to understand, make sure you understand for the exam. Knowledge of benchmarking principles and sources of best practice information. I think the best place to get this, the best thing to do strategically, understanding that you don't have all the time in the world, is to understand the benchmarking system that value-based purchasing uses under CMS. That is going to get it's going to give you an understanding of how they use benchmarking, how they establish thresholds, and that will apply to Leapfrog or whatever other program you're looking at. So if you stick to the federal stuff, you'll get a good understanding on it. The methods of medical staff peer review. I think that there's a good piece of that in the well-managed healthcare book. That's probably the best place to go for that. Risk management and compliance, same thing. Well, there's a lot in that well-managed healthcare book. Knowledge of performance and process improvement tools. I would really understand theoretically what lean methodology is. Fundamentally, it's about reducing waste. And if you reduce waste, you will be more efficient, develop a better product or service in this case, and it will actually give you a strategic or market advantage. Six Sigma, similar, right? Six Sigma is really about eliminating defects, but it's a strategy. It's a strategy for it's a strategic initiative. And then understand the specific tools that fall under those. So things like root cause analysis, define, measure, analyze, improve, value stream mapping, cause and effect, plan, do, study, act. I would just review those things to make sure that you understand them theoretically. Also, understanding the bottom-up approach would probably be important. And we saw a little bit of that alluded to in the IT question of, forming a committee or whatever it was, who should be on that committee to select a system. You got to get down to the people that are actually doing the work, the people who are actually in the processes, using the product, touching patients, to understand that. And in quality, it works the same way, right? It doesn't really do a whole lot of good for somebody at the top just to be saying you should be doing this and you should be doing that without an understanding of how things go kind of at the bedside or on the floor. Let's see, next slide. We talked about performance and process improvement tools a little bit, or I did, but understanding clinical pathways and evidence-based medicine and sort of how they're built, how they're structured, and then also the utilization and medical review process. So going back and figuring out, were clinical pathways followed? Do we have a robust evidence-based medicine program? All goes back to data, right? So does population health. And then as far as performance measurement tools, again, knowing that you don't have all the time in the world, I would go back to value-based purchasing on the federal level and understand how organizations collect and report data to that program. And I think that gives you a good broad understanding of how you would do it for everything else. I would take a look at HCAP specifically, the Hospital Consumer Assessment of Healthcare Providers and Programs. I would take a look at the instrument And then understand that there are CAHPS surveys for lots of different types of delivery organizations, but HCAHPS is the primary one that we're all familiar with. And so just a good understanding of that will help you understand the rest. Tools for improving patient safety, understand variation, what is acceptable variation in a process and what's not. So random variation versus special cause variation is an important principle to understand for safety. And then I would say like 3 or 4 specific definitions to remember. Understand the difference between a latent error and an active error. An active error is an error that it's a human, right? A human makes a mistake. A latent error is a problem in the system that causes an active error. And most often, active errors are caused by latent errors. It's not just somebody who's bad at their job. It's somebody who is in a system that is almost directing them to make mistakes. Also understand diagnostic, treatment, and preventive errors as well, and how to sort of categorize them and maybe some examples of each. Okay, so I think we can move on to the questions. And I will, I'll read you the question, and then we can do just like we did with the IT stuff. You guys can put your answers in the chat, and then we'll kind of walk through them and see if, you know, try to make some sense out of them. So critical paths are important because they what do we got?
Some bees.
Okay, lots of bees coming through. Okay, yeah, so provide support in a malpractice suit. I don't know, maybe. We'd have to get an attorney to answer that one. And I don't think Rick's around. I'm kidding, Rick. Delineate best practice protocols. That's a possibility. So we want to kind of mark that one. Increase patient throughput. They could do that, and reduce resource use. They could do that as well. So this is kind of one of those things where there are a couple or a few plausible answers here. We're obviously looking for the best one. So show us the answer. All right, so I think everybody, maybe not everybody, but almost everybody answered B. And yeah, I mean, critical paths are just, they're going to guide you. They're going to be the best guide to an outcome. Let's put it that way. They may increase patient throughput, but they may not. They may reduce resource use, but they may not. But if they're followed, they certainly will delineate best practice protocols. Number 2, which characteristic of a high-risk process would tend to increase the risk of a process failure?
This is a tricky question, huh? For me.
Yeah, read this one really
Mhm.
carefully. You might want to read this one backwards. Getting some C's. Got an A and a D in there.
Okay, so we got a lot of C's, and then a couple others. So again, reading the question carefully here. This is one of those where I can see myself sitting down for an exam and just blowing through this question and answering it incorrectly because I didn't notice the word increase. And so that's the key here. Which one is going to increase the risk of a failure? Increase the risk of a failure. So simplicity in a process is good, right? Especially when we have human beings carrying out that process. We want it to be as simple as you can make it. You want it to be thorough and all that, but simplicity is good when humans are involved, usually. Consistency, that's good. We get really good at things when we are consistent in them, when the instructions that we follow are consistent, when the steps are consistent. Variability, that one seems good and likely to me. And automation, again, would decrease the risk of a process failure. So yeah, so the answer is C, and someone put in the chat in parentheses control chart. Yeah, so control charts help you identify and analyze variability and whether or not it's an acceptable amount of variability. We have to remember that there's variability in everything. And we just really want to know, is it too much or not? Always have errors, we'll always have variability in processes. Control charts help you sort of apply a statistical model to put limits on it, on a process variability. Oh yeah, that's true. Somebody in the chat said, I was thinking that if you automated a high-risk process and got it wrong, that wouldn't be okay. I mean, that is true. That is true. If I don't know, let's say take some step in a process like scanning somebody's wristband or something like that at the bedside, sure, yeah. If that was if there was a problem in that automated system, that would be bad. However, if you automate a system and you get it right, then the automation does the job for you, and it does it over and over and over again, and it does it reliably, and you don't have to worry about it. But yeah, you're right. You got to design good systems on the front end. Okay, in conducting a risk assessment, what would be the first action to take? So risk assessment, first action. The very first thing you'd want to do.
Got some A's, got a D, A, D.
So let's look at this. I mean, the thing about this question is that they're in order. The very first thing you'd want to do is just identify, well, you already know what the process of concern is, so you need to identify the steps in it. And then you analyze those steps and you find out what could fail. So tool for this, going back to Six Sigma, would be a failure mode effect analysis. And then you identify the causes of the failure in that process, and then you set your priorities for fixing it. And so, so the answer is A, this one. Okay. In designing a risk management program for your organizations, what approach would have the most impact on reducing risk? Reducing risk.
We've got an A, a B, a couple of Ds,
The,
a B.
okay. And a lot of hesitancy here. And there's, I mean, yeah, this is kind of a busy question, busy
Yeah,
moment.
a lot of words.
Yeah. Okay, so let's start with A here. Okay, going back, we want to design a risk management program, and we want to know, the question is, which one is going to have the most impact on reducing risk? So A, developing a reporting system, that's great. You know, every organization should have one of those. But that's after the fact, right? That's a quality control initiative, not a quality assurance initiative. Quality control is after the fact, and it's fine if you're it's a fine component to have in healthcare, and it works great if you're manufacturing cars or something. Because cars aren't injured in the process, right? So we want to be thinking quality assurance. We want to be thinking about designing systems and processes at the front end to avoid that kind of stuff. Let's go down. I think we had a D in there. Educate staff on potential risks. That's important too. C, use task forces to address key Joint Commission standards that apply to risk assessment. Sure, we'll always just set up a committee, which is always great. But obviously, Joint Commission compliance is important, but it doesn't really get at the impact on reducing risk. B, require assessment of high-risk areas or processes within each service department and unit. That's the place to start. That's going to give you the most bang for your buck. It's going to, the other ones are fine. They just don't help prevent much. Educate staff might, but it doesn't change the process. It won't affect the process. It'll be something sort of ancillary to the process. But again, we want to get down to really it's processes, not people. And so the solutions are processes, not people. So the answer is B.
Yeah. So Stan, this is Michael. I would like also to add, like, first you have to identify the risk or high risk area or processes. Like, for example, in the hospital, what are your high risk processes like C. diff outbreak? So you have to identify those. So then you can develop a process to improve that and monitor. So just
Yes, great. Okay, what action would you take to ensure that all critical activities associated with care of a patient are being carried out in the right sequence?
I'm even getting stuck on this one. I'm going down rabbit holes. Got a B,
And we got a B.
A, B's, another A. B,
Okay. So going back to the question, we want to ensure that all critical activities associated with the care of a patient. So we're getting down to the patient level here, and what would apply to the treatment, the care of a single patient. And so Clinical practice guidelines, fine, right? Those are great. They're sort of guardrails. They're wide guardrails. Think of, I don't know, freeway in Houston. Right, but there's a lot, you can do a lot within those guardrails. Clinical pathways are specific. They're evidence-based, based on specific diagnoses. You are supposed to do these specific things. And obviously there's a little bit of variation, but it's a very narrow highway. Disease management program is just, that's more of a broad-based, could be a population health kind of initiative. Evidence-based management program, that seems plausible here. But the most direct sort of associated with the care of a patient is B. And I think most people got that one right. That's at the point of care. And so if we're digging into that question, the text of that question, the care of a patient. All right.
And a good definition of the clinical pathway for tool ensuring all critical activities. And again, yes, choosing the broadest answer worked.
Yeah. Okay. Your medical staff, your medical staff on the general medicine unit has been complaining about the delays in administrations of medications. You study processing times on other units and you find that they're considerably longer on the general medicine unit. What's the first step? The very first step.
Got a D.
Got a D. Got a few more Ds. Okay. Yeah, let's walk through the options here. Implement best practice from other units. I mean, that seems like it might be okay, but there are other units, right? And so the needs on the general medicine unit could be different. There could be reasons to have different processes on one unit versus another. Have the manager from the highest performing unit assist the general medical unit in its improvement efforts. I mean, that could be useful somewhere down the line. This person may know something that other people don't and have some, advice to lend. Establish benchmarks for processing time across the organization. It's not useful at this point. If you establish benchmarks using existing data across the organization, you're going to be using what you got in a poor performing general medicine unit when it comes to this stuff. So it wouldn't be very useful at this point. Organize a process improvement team on the general medical unit. That's the answer, right? That's the very first step. And first step is right there at the end of the question.
Mhm.
All right. Move on. What tool is appropriate in identifying priorities for actions?
Sorry, guys, you gotta know the definitions of each of these. So we got some C's.
Yeah, we've got some C's.
Mhm.
So if I were you, I would know what each one of these is. Make sure you understand what they are and how they're used. A flow chart, visual description of a process. Cause and effect diagram. This is also known as an Ishikawa diagram or a fishbone diagram. And so all of those are the same thing. This is where you start with an outcome and sort of brainstorm causes of that outcome. So you start with a problem. So it can be used as sort of as an element of root cause analysis, but it can also be used as a method of brainstorming of what might go wrong. The Pareto chart, the Pareto principle related to the Pareto chart is called the 80-20 rule. And that is the theory that 80% of your problems are going to be coming from 20% of your factors. So it helps you prioritize where you're going to allocate resources for improvement. And then a run chart is a historic chart of something over time. Yeah, so the answer is C. I think that the Pareto chart, the 80-20 principle, I use it all the time. I don't actually make Pareto charts all the time, but I sort of like walk it through. When something's going wrong, I say, okay, where are my problems coming from, and how do I prioritize resources to fix those things? And you think about employees, right? You have a small handful of employees that are causing a lot of headaches, right? 80% of your headaches. The other ones are usually great. Anyway, okay. So next question. What approach best ensures loyalty by patients to your organization?
Got some Bs.
Yep. Okay. We got a bunch of Bs. B is the answer. To engage patients, actually get them involved in care, involved in the organization in any way they can be, whether, patient-related committees and stuff like that. Patient satisfaction surveys are after the fact. I think that most people think that when they fill those out, they go off into the ether and who the heck knows what happens to them. And actually, as a side note, I'm a professional patient. I get it. I'm in the healthcare system all the time, and that is what happens. I've said horrible things on patient satisfaction surveys. I've never heard back from anybody. My vet will get back to me, but that's for my dog, so it doesn't count. Effective complaint resolution process, fine. It's good to have, but it's after the fact, and something bad has already happened. Patients, they don't understand a lot of the challenges that healthcare organizations deal with and a lot of the complexities of it, but they understand what they need. They understand what they want, and we need to hear that. And yeah, in theory, that not in theory, but it does help ensure loyalty, I would say. Okay, next one. A healthcare institution would use nationally accepted clinical benchmarks to
Getting some Cs.
okay. Lots of C's coming in. Let's take a look at A. Determine what services the institution should offer to meet the needs of the area. That's more of a needs assessment. So not related to benchmarking. Obtain a comprehensive view of the state of the institution's business. Unrelated. Let's see. Oh yeah, everybody was C. So evaluate the outcomes of a clinical process. This is the only one that really fits here. So you're trying to assess clinical outcomes. A clinical benchmark, a nationally accepted clinical benchmark, will give you something to compare it to, right? To compare your outcome, your performance outcomes to oversee the clinical structure of the institution is not even possible there. So C is the correct answer. The dual nature of quality is important for healthcare managers to understand because dual nature.
Some C's, we've got a D. Got an E. Some B's.
Or B's, okay. Okay, so let's start at the bottom. Let's start with D. Each competing aspect of quality works against the other unless clear defined management roles are embraced. Competing aspect of quality works together. I don't know. That's an interesting one. Or works against the other, sorry. Maybe, but that doesn't really address the question, the dual nature of quality. So we're talking about fundamentally how we think about quality. Let's go to C. Managers can only impact administrative aspects of quality while physicians control the patient encounter. They must work together to achieve total quality. I mean, physicians do control the encounter, but a lot of the processes that administrators implement have a lot of effect on how patient encounter goes. So I've talked a lot about building the right system. That's the system that physicians, other clinicians work within. So that's probably not it. Content quality and service quality, B is the answer. There's the subjective quality and the quote objective quality. The patient experience versus the clinical quality. It's the different ways of saying content quality and service quality. And honestly, I understand what is meant by content quality, and I don't know where this question came from, if it was from a flashcard or something, but that would make me pause a little bit, just because I would call content quality clinical quality, and I would call service quality patient experience, but that's probably because I'm deep into the like value-based purchasing stuff or something. But the answer is B.
Yeah, this isn't on the flashcards, but
Was it?
no,
Oh,
no,
wasn't
not this particular one,
Yeah.
but
Yeah.
you did a good job of explaining why it would be that. And again, a lot of words and some of the other stuff.
Yeah. And
Um,
I think, I've looked at those flashcards quite a bit, and I almost think, and I know you said it wasn't, but it just kind of reminds me, there should almost be a crosswalk a definitional
Exactly.
crosswalk because we use different terms for the same things in different
Right.
organizations and stuff, but yeah. And is there more questions or is that it?
Yeah.
Oh, that's-
Okay, I think that's it,
Any
Stan.
questions?
I think between the presenters today and the questions and everybody's participation, this was a fabulous session.
So,
Can I ask a quick question? Stan, I know we're getting a lot of attention to AI generally, but in healthcare, it seems like it's been growing, particularly radiology. Do you think it's reached the point of being standard enough that, or common enough that people could expect questions about it?
I think it's obviously, you can hear the latest and greatest bells and whistles, right? ChatGPT is everybody's mind, and but AI has been actually been relevant for a few years now in terms of where healthcare can really benefit from it. I think radiology comes to mind as a first big successful application of AI. The challenge really is about the amount of data that AI needs to really interpret the data and also come up with, kind of summaries, prescriptive diagnosis, things of that nature. It's definitely going to be more and more relevant as we move forward. Not the kind of, ChatGPT is able to answer all of the USMLE exams, that's not relevant in terms of what the, how it impacts the care that we actually deliver, right? I've read a story about, I don't know if it's true or false, that an emergency department, whether it was a test or they actually rolled it out because there was no ER physician available, was using ChatGPT to assess the patient's condition and to figure out what to do next. Right, that's the scary part of people relying on it to kind of figure out what's, how we should really care for the patient. So it's a long way from there where we are right now, but there's a lot more relevance to it, definitely, and you should see more and more questions come up about it.
So it's just one more thing that people ought to at least be thinking about and have some basic idea of what it is and how it applies in healthcare.
Yes, definitely.
okay. Okay.
So,
Thank
really
you.
quick, let me, okay, we've got a question in the chat, but really quick, we do have a section on, final comments of stuff that we've discussed all along. Please read it. Again, it's just kind of reinforced what we've been discussing this entire session. And then for Sumit, I hope I'm pronouncing your name correctly. You want to know how the rest of us prepared for our exam, or how we knew when we were ready. I think for each of us it's a little bit different, but I believe most of us would have, studied as much as we could on the knowledge areas, do the assessment, and then sometimes you just. Some people have, when they can take the exam for free, they take it then and they're surprised if they pass. But I think if I say the royal we, if you feel that you have a good knowledge of the knowledge areas, when you do your assessment, if you find the ones you're weakest at, if you can concentrate on that and take the leap. I don't know, am I speaking out of turn, guys?
Yeah. Okay, thank you. We are all 6 minutes over. So I hate to, it's a good discussion. Actually, it's very engaging today. And thank you to our speakers. And I think we're ready to close, right? So I would like to, thank you, all of you, for joining us in the last 5 weeks. So we appreciate your participation. Your presence denotes your commitment to the life learning and to your FACHI journey. So we hope that you gained some benefits in attending our sessions. As we, always say, pay it forward. Please keep us updated in your progress, and we look forward to your feedback. Good luck and wish you all the best, and goodbye. Thank you.
Send us your pictures once you get your certificate. We'll put you on our wall of fame.
Yes. Best of luck for everyone, and thank you for joining us.
Thank you.
Thank you.